Welcome back, and thank you for joining me today as we discuss disorders of the endocrine system. Today, we're going to be talking about disorders of the pituitary gland. So, remember that your endocrine disorder is either excessive or deficit in production of a specific hormone. So, gigantism is an oversecretion of growth hormone that occurs before puberty. Dwarfism is an insufficient growth hormone during childhood. Now, acromegaly is the oversecretion of growth hormone during adulthood. And the absence of pituitary hormone activity is also known as your panhypopituitarism or Simmons disease. Now, acromegaly, like I said, is your hyperpituitarism is your acromegaly, and this is the oversecretion of that growth hormone. So, with that oversecretion of growth hormone, you're going to have lengthening or longer bones, and the bones are going to be wider. That hypersecretion is going to cause hypertrophy, which is an increase in cell size. You can have hyperplasia, which is an increase in the number of cells, and oftentimes that hyperplasia can cause tumor formation. Your assessment findings. So, when you think about that longer bones and the wider bones, you're going to see coarse features such as a huge lower jaw. The lips are going to be thick. Their tongue is going to be thickened. A bulging forehead, severe headaches, increasing head size, and visual disturbances. The nose can be bulbous. They can have large hands and feet and even joint pain. The organs may become enlarged. They may have weakened muscles, a barrel shaped chest, decreased libido, and hyperglycemia, which is an increased blood sugar. So, what are some of the causes of this, or what is the risk factor for hyperpituitarism? Well, the risk factor can be age, because you never know what's going to happen. It can be age, and it can also be a benign tumor, which is a pituitary adenoma. How do we diagnose this patient? Well, we're going to do growth hormone levels and draw some serum blood and look at those growth hormone levels. We can also do a glucose tolerance test as well. So we can do that glucose tolerance test. Then we can do a series of x-rays because we may be looking for a tumor, remember? So we can do x-rays of the skull, CTs and MRIs of the head, and even cerebral angiograms because we're looking at that flow of those vessels. So we have both medical and surgical treatments for this client. Surgery is going to be a hyposectomy and radiation therapy as well. So the hypopysectomy is going to be removal of that tumor, or removal of, I should say, of that pituitary gland. They're going to remove the pituitary gland. If they can't remove the pituitary gland, they may do radiation to decrease the size. So either way, the client's going to have some type of hormone therapy, hormone replacement the rest of their life. So part of our nursing management is going to be teaching that client about that hormone replacement therapy they're going to have to take. We're going to pace those activities because we're going to be very conscientious of that pain, those large joints, painful joints, the headaches, that kind of thing. We're going to be very mindful of their pain and pace their activities. We're also going to give them pain medication to help relieve some of that discomfort that they're having. And of course, we're going to encourage that self care. Now, if the client had a hypopysectomy, you're going to need to monitor that client closely for any CSF fluid, which is your spinal cerebral, I'm sorry, it's your cerebral spinal fluid, your cerebral spinal fluid discharge. So they may have a nasal packing in, and you are going to check that packing every time you go in and check on that patient. You're going to keep that head of the bed up. You're going to check that packing for any fluid discharge. You're going to encourage the patient not to drink through a straw, not to sneeze, no coughing, and don't bend over, because there is a packing, or I should say a graft, that they use to seal the nose and the brain area where they go in nasally, for that hypopacectomy, where they go in nasally with that. They're going to put a graft there to seal off any of that spinal fluid that can leak out. So you don't want them to dislodge it by drinking through a straw, sneezing, coughing, or bending over. So we're going to encourage those things with that patient. Now, as far as our Simmons disease, that's your panhypopituitarism. And this is when the anterior pituitary hormone activity just stops. There's no hormone secretion at all. Now, the causes for this can be congenital. It can be a postpartum hemorrhage or a postpartum emboli. It can also be the result of surgery or a tumor. Can also be a cause for that. So the clients are going to present with hypothyroid type syndrome symptoms. They're going to be hypoglycemic, which means their blood sugar is going to be low. They can have adrenal insufficiencies, gonad and genitalia atrophy, as well as premature aging, cachexia, cachexia, which is also like a malnourished or a wasting away look that the client may have. So to treat this, we're going to use substitute hormones, because remember, there's no hormones being produced, no hormones being secreted, so they're going to have substitute hormones for this. The clients have to be taught to take that medication on a regular basis. They can't just stop taking their medication, and we're going to also monitor those hormone levels as well. Now, moving on to your anti-diuretic hormone, your ADH, which is also known as vasopressin. We're going to be looking at DI and SI-ADH. DI is your diabetes insipidus. So the role of the antidiuretic hormone is altered, and it can be neurogenic or nephrogenic. It can be either from neurogenic, which could be a damage or deficit of the hypothalamus that can affect that, and then your nephrogenic, or your renal tubules are partially or completely fail to respond to the antidiuretic hormone. So those are the two types that you can have. So the assessment findings for this client is going to be polyuria. And when I say polyuria, I'm talking about 12 liters in a 12-hour shift. That's not unusual. Mega urine output. They can have weight loss, thirst, weakness, and dehydration. So make sure that you're monitoring for that. We're going to diagnose them by doing a fluid deprivation test. We're going to also look at that urine specific gravity. We're going to look at that urine specific gravity and see what that looks like. The treatment, of course, is going to be drug therapy. Lots of times we're going to use that DDAVP, which is a vasopressin. We can give that nasally, or if there are signs of dehydration, such as a low blood pressure or high heart rate associated with dehydration, we can give that vasopressin in the form of an IV. We can also do some thiazide diuretics as well. Our nursing management is going to be to correct that fluid deficit. So you have to know the signs and symptoms of dehydration. Low blood pressure, which is hypotension, and a high heart rate, which is your tachycardia, can be a sign of dehydration. So you have to monitor for those deficits with your DI patient. So we want to increase those intake of PO fluids. We're going to measure that urine output frequently. Like I said, we're going to correct that fluid deficit. Your DI, these patients have increased sodium levels. Their urine chemistry is very dilute. With their serum chemistry, it's going to be very concentrated. Maintain that sodium between 135 and 145. With your SIADH, your syndrome of inappropriate anti-diuretic hormone, you have an excessive release of ADH, and this can be caused by lung tumors, CNS disorders, which is your central nervous system disorders. The client can have a CVA, which is a stroke. They can have head trauma, and even some medications can cause this, such as some of your psych medications can cause this. Our assessment findings with this client: water retention, headache, muscle cramps, anorexia. They can have nausea and vomiting, muscle twitching, and of course changes in their level of consciousness. So we are going to be medically to correct this. We're going to remove those underlying causes, or we're going to address those underlying causes. And if they can be removed or eliminated, we're going to do that. So, like with a head trauma or with a CVA, it may just be a matter of waiting that out until that improves on its own. There may not be a lot we can do with that. So, we're going to treat them with osmotic diuretics if we can't eliminate the underlying cause, and treat them with osmotic diuretics. Loop diuretics such as Lasix. We also can give some 3% hypertonic normal saline and vasopressin as well. So remember with this, the posterior pituitary is the cause for this disorder. So you have that posterior pituitary is not regulating that antidiuretic hormone like it should. And so they're going to have that hyponatremia. That's why we want to give that hypertonic solution, which is a 3% normal saline. That has to be administered in an ICU or an emergency room, some type of critical care area, because it has to be monitored closely. Nursing, as far as nursing goes, you're going to look at those I&Os, vital signs, assess that level of consciousness, see if there's any changes. Closely monitor for signs and symptoms of fluid overload, because remember, this is fluid retention. They're retaining fluid here so they can become overloaded. And family and patient teaching for those signs and symptoms of the SIADH, especially if they take some medication that's prone to causing this disorder. So with this client, they're going to have urine chemistry. This one's going to be very dilute as far as their sodium and osmolality goes. So you're going to be looking at the urine chemistry and serum chemistries as well. So whenever you're looking at the side-by-side comparison on the PowerPoint, you see that with DI patients have a high urine output, they have low levels of the ADH hormone, they have hypernatremia, they're dehydrated, and they lose too much fluid, meaning they urinate a lot. With your SIADH, they have a low urinary output, remember, because they're retaining. They have high levels of ADH. These clients are hyponatremic and they're overhydrated. Remember, they can have fluid overload because they're retaining. They retain too much fluid. Both of these clients will present with excessive thirst. So hopefully the side-by-side comparison on your PowerPoint will help you to distinguish the two disorders. And that concludes it today for our pituitary gland disorders. Thank you for joining me.